All right, so hi everyone, and thank you for joining us. We have a very important and interesting speaker. It is my pleasure to introduce Dr. Consuelo Wilkins, who's a tenured professor of medicine, senior VP, and senior associate dean for health equity and inclusive excellence for Vanderbilt University Medical Center. Dr. Wilkins is nationally recognized thought leader in health equity and in addressing the elimination of systemic inequities that impact the health and well-being, specifically of minoritized racial and ethnic groups. Throughout her career, her research has focused on racial and ethnic health disparities using a community-engaged approach. She's currently principal investigator of several NIH grants, including BNPI on the Vanderbilt CTSC. Dr. Wilkins has received many national awards and honors. She's an elected member of the National Academy of Medicine. So without taking more time, Dr. Wilkins, we're looking forward to your talk, and thank you for being with us today.
Thank you so much for the invitation. I am pleased to be with you all today. I am going to share my screen, and I have quite a few slides. So just a heads up, I may not get through all of them, but I want to make sure that I open the opportunity for people to feel free to interrupt me if there are burning questions or things that you would like me to delve deeper into. So as you've already heard some of my background and some of the funding that I have, I don't have any industry funding as at the present time. I'll actually just make a couple of points about some of my work in clinical and translational research. So it was already mentioned that I am one of the PIs of our CTSA in Nashville at Vanderbilt, which is a partnership with Meharry. We also have an administrative supplement that's focused on community engagement with the Compass program. And I'm going to mention briefly my role in the Trial Innovation Network. I am one of the principal investigators of the Recruitment Innovation Center, which is based at Vanderbilt. It's the only recruitment innovation center that's part of the Trial Innovation Network, and I get to co-lead that with Paul Harris. Again, I'm sharing those things in case there are burning questions about those. Hopefully we'll have time at the end for me to answer any related questions. But the key objectives that I have for today are listed here. So I want to focus on embedding equity and engagement in clinical and translational research and science. I think this is an incredibly important time for us to be focused on these. And specifically, I think it's important to acknowledge and recognize the historical and ongoing role of science and medicine in really creating systems of inequities and oppression, and think about how we can embed some approaches to address these in our research, making sure that our clinical research is scientifically just and inclusive. And of course, a key element of all of these is really thinking about how we meaningfully engage communities in research, especially communities that have been historically marginalized and experiencing health inequities. I want to acknowledge the 2003 Institute of Medicine report on equal treatment, which I imagine many of you are very familiar with. I bring it up today because just yesterday we actually released our follow-up to that 2003 report. So I had the honor of being a part of the National Academy's committee that revisited the unequal treatment report and looked back over the last 20 years. And so just yesterday, we released the consensus report, Ending Unequal Treatment and some strategies to achieve equitable healthcare and optimal health for all. Sadly, we saw that these inequities remain and have been present for now many decades. But even looking back over the last 20 years, we continue to see worse health outcomes for people from minoritized racial and ethnic groups. And you can just see some examples of that here in the 2021 AHRQ report. But in the report that we just released yesterday, we have 5 overall goals that we suggest for ending unequal treatment, and there's 17 recommendations. And so I'll point out a couple of key ones that are really relevant in terms of research, and that's the goal number 1, which is generating accurate and timely data on inequities so that we can inform decisions. And goal 3 is really about investing in research and evidence generation to better equip us to end these inequities. And there's an explicit focus on community engaged research, as well as multi-level interventions and interventions that are looking at upstream social drivers of health. So to my first objective, how has science and medicine have contributed to creating and maintaining health inequities? We all often think about the historical issues within medicine and how segregated care really had a substantial impact on health outcomes. And of course, the remnants of that continue to exist even now. But the issues around inequities go beyond just the healthcare setting. In science, we have baked in myths about differences in groups based on race. We've been really buying into and actually confirming these false notions of differences, racial differences based on biology. And it's really important that we reckon with this, that we acknowledge how racism continues to be a part of our work. There's a great paper in the New England Journal of Medicine in the last couple of months that looked at how using race-based results or norms for results for pulmonary function tests have impacted people, especially individuals who are Black. And so up until recently, we were, most of us in our health systems were using a normal ranges for pulmonary functions tests that included differences by race. And this can actually be traced back to the 1860s when Samuel Cartwright, who was a physician and a slaveholder, documented that there was lower lung capacity among enslaved people who were descendants of African people. Even though I've presented this slide many times, it's still difficult to even read the caption that he used this this observation, which has not necessarily been consistently documented, but saying that this was a reason to keep people enslaved, that Black people should be enslaved and meant to work with a lot of physical labor, because that actually would increase the oxygenation to their brain. So these types of horrific ideas that were not based on science, but were published and embedded into our health systems are still around today. If you've not read Harriet Washington's book about medical apartheid and looking back at medical experimentation and its impact on people of color, please do. But again, emphasizing that that's not just history. These are things that continue to exist today, we have many algorithms that continue to use race as a variable, even though race remains one of the most imprecise variables that we can use in terms of a quantitative measure. We've seen continued evidence of the lack of inclusion of people of color in our work, and how that can have adverse impacts. So we saw this quite a bit during the pandemic with pulse oximeters being less accurate for people who had darker skin, and that had an impact on whether or not people receive supplemental oxygen and other aspects of care. So we have to acknowledge that often when we're looking at racial and ethnic health inequities, that racism, not race, is really the driver of these. And so thinking through, again, how we use race in research and acknowledging that race is a socio-political construct, that it is something that is not based on a biological basis, that it's fluid. It can, just looking back at the census and even how we document that in the United States, there have been shifts on how people are identified. There are differences in how race is considered in other countries. And in the United States, historically, race and ethnicity have been primarily used for the purposes of oppression. And this is one of the examples that I often go back to about how imprecise race is as a variable in human research, and the idea or the notion of hypodescent, and actually assigning people to a racial group that's presumed to be of inferior social status is something that was a common practice in the United States, and still is in many ways. So the idea that I can be a Black woman and have one great grandparent who is Black and still be considered Black, versus I can have 8 Black great grandparents and be considered Black. So that again is illustrates that this is a social and political categorization, and not having to do with biology. In our work at Vanderbilt, and this has been part of a couple of different studies that have been NIH funded. One was a center on disparities in precision medicine, which I was one of the PIs on, and it was a partnership between Vanderbilt, Meharry, and the University of Miami, where we actually, this work was led by Kiera Atkins, who at the time was a graduate student at Meharry, working in one of our Vanderbilt labs. But when we look at these two concepts of race and genetic ancestry, and using our EHR, our BioView as our genomics database, which is connected to our EHR, when we look at African ancestry and control for what would be Black or African American race, the conditions that were most commonly noted in the EHR, kidney disease and sickle cell anemia, which, as you know, have well-known connections to genes, genetics, genomics. However, when we look at the social construct of race and look at people who identify as Black or African American, and we control for the African ancestry, the most common conditions you can see here are race and more vague symptoms of fatigue, which are associated with discrimination, experiences with racism, living in marginalized and disinvested communities. And so, again, we have to push ourselves to move beyond these notions about race that we've held on to for a long time. And the picture that you see on the left here, these beautiful young ladies are twins, they're fraternal twins, and you can imagine them experiencing life very differently, especially in the United States. And so the eugenics and these false notions that really connect superficial physical characteristics with biology. These were notions that came from scientists. And so over the last few years, we've certainly seen more people reckon with the idea that science has contributed to this legacy and the false notions about how people, the false notions about biology, about intelligence, about so many things are really society that was shaped, these aspects of society were shaped by scientists and physicians. And so recognizing that racism is very much apparent in our society. It is not, science and medicine are certainly a part of that as well. So we don't get a pass from this because we believe that we are, in these noble professions, and somehow we are exempt from having a role or being influenced by racism and bias. And so often we are thinking that about racism as the tip of the iceberg, with more interpersonal racism, when actually, again, it's built into these structures and systems of oppression. One of the things that I've seen a lot lately is the notion of being colorblind, and so this we tend to be more comfortable with the idea that that color is that you can't see color, that we just treat everybody the same. But the reality is that that's not how our systems have worked, and that's something that we note quite a bit in the recent National Academies report that I just referenced. So ending unequal treatment is that racism continues to be a big driver of health and health outcomes. Often when I'm talking to my colleagues in science and medicine, again, that overlap between, well, we're seeing differences in people based on race and ethnicity. So how can it be that they're not biological differences? And so I noted that certainly there are some genetic or ancestry things, but those are about individuals and populations that can't be applied broadly to people based on these social constructs of race. But what happens when we experience racism and discrimination, and we have to live in communities and in social conditions that are marked by deprivation and disinvestment in our communities, we have an increase in our allostatic load. And regardless of the driver of that, physiologic stress leads to many, physiological changes. And so those are the things that we end up seeing. So we see increases in diabetes and hypertension and other conditions in communities of color, but it doesn't mean that that being a person of color or having a specific race or ethnicity is the cause of that. But being in conditions and systems that are oppressing and marginalizing people can have that impact on them physiologically and increase the risk of these chronic conditions. It's also important to recognize that, again, the ongoing how racism will continue to have an impact on the work that we do. This is, if you're not familiar with Color Code, a podcast that folks at Stat News created over the last couple of years. This particular episode, Racism is America's Oldest Algorithm, How Bias Creeps into Healthcare and AI, is a fascinating one. I've shared the story with a couple of people before that, I operate in a mode of efficiency. So I think a lot about how am I going to get my work done, all the things I have to do. I say E is on my family crest for, how can we do things faster and more effectively. And so one of my life hacks is I listen to podcasts at 1.25 speed so that I can get through them faster. So this was one where I was on the elliptical and it was so the content was so profound to me that I actually had to stop the elliptical and change the speed to go down to one. On the podcast speed so that I could hear everything that was said. So if you have a chance to listen to it, I recommend it. But you know, the idea that we're going to now use AI for everything, and we don't have quality checks, equity checks to think about how the data that we're putting into AI is already biased. So for example, in our health system at Vanderbilt, we do not, there are only some of our clinics that take TennCare or state Medicaid. And so we see a more privileged population of people. So if we're using this data to generate anything, we have to acknowledge that we're not seeing people who are some of the most socially deprived. So what are we going to do about it? You know, a lot of emphasis recently on health equity research, and I'm very thrilled to see this focus and push. You know, a few things that I would note here is that it's important when we think about health equity research that we're moving beyond documenting disparities. So much of the literature is about documenting differences and not moving towards solutions. Critical to health equity research is that we have an emphasis on social drivers. And so there needs to be a framework that considers social factors as a part of your research. And the work has to focus on a marginalized group. It doesn't have to be specifically minoritized racial and ethnic groups. It could be sexual and gender minorities, people with limited socioeconomic status, as well as individuals who are living in underserved rural communities. If you're doing your health equity research, thinking about, again, how to embed equity into the work, a critical piece of that is having an interdisciplinary or a transdisciplinary team. And so you really need to have investigators who have knowledge and experience with social and structural drivers of health. Partners in the community are often very critical to this work. And I think that something that we've seen recently is this the importance of having researchers having a commitment to health equity. So many communities describe this helicopter research where people come in, researchers come into their communities and they just want to do research on them, not with them or considering what their needs are. There's some important and more innovative approaches also around using principles of equity in your statistical analyses and interpretation of the work. And so it's incredibly important that people who are doing health equity research are thinking about these, that they are trained in it, and that they are willing to continue to be educated. And so a lot of attention also in the last few years has been on the idea of health equity tourism, so that, you know, with the increase in funding and health equity research, especially after the pandemic, we've seen more researchers move over or want to move over into health equity research. And there are some good things and not so good things about that. So, I mean, we have so many health inequities that we really need more people who can help study and move the needle here. But we need those people to be trained appropriately and committed to health equity. So those of us who've been doing this work for decades with very few opportunities for funding, we're ecstatic to see so many more opportunities. But then we also see people who are not trained, but our experience with writing grants, getting those awards, and that can have really many impacts on the work with evidence being generated that's potentially harmful. And so these are important things for us to consider. Another aspect of embedding equity is thinking about data and how we use data to drive and evaluate change, not just document inequities is something that I mentioned. We also think that often the lack of data is being used as an excuse or is used to question whether or not we need to be investigating inequities. And so I think we are having some important shifts here. This single question for how we collect race and ethnicity data is actually something that has been used in the All of Us research program. I'm sure many of you are familiar with this. We at Vanderbilt were responsible for pushing this forward and collecting race and ethnicity and Hispanic ethnicity as a single question. And of course, just in the last few months, in March of this year, OMB issued new guidance, federal guidance on collecting race and ethnicity as a single question, with the addition of Middle Eastern or North African as an option. Check all that apply, and also collecting additional data. And so this is, really important as we can think about how people identify themselves. And this is an example of how we have used data in a way that with a lens that's focused on equity. So here's data from our COVID-19 health equity work stream. So I had the opportunity to design this as part of our COVID command center. And of course, we, like most places, were disaggregating the data by race and ethnicity. I point out here unknown race. So often when we're doing our research, if we don't know something or we describe it as missing, then we actually don't include it in the analysis. And so you can see here the group of people for whom we did not know what their race was actually had the highest percentage of COVID, positive COVID tests, 21.3%. And what we think this actually represented is something that we did find, that we did have data on, and that's the languages. So when we look at languages, all of the languages other than English, preferred languages, you can see here that group had a higher COVID positive test here. And after English in Nashville, Spanish and Arabic are the second and third most commonly spoken languages here. You can see them here. But we also found that, this Nepali speaking community, which is relatively small in Nashville, had nearly 30% positive. And that actually allowed us to work with community organizations to identify some community-specific strategies to address what we found there. We also looked at our data by zip code. And so the zip code that had the highest COVID positive rates, it was here, and that's in the southeastern part of our of Nashville. And you can see here some important aspects of those communities. So they're more likely to, compare to the metropolitan area, a higher percentage of people live in that zip code who are Black, Hispanic or Latinx, slightly higher for Asian American, more likely to speak a language other than English at home, more likely to be born outside the United States, slightly higher household density here. They were actually more likely to be employed, although they had lower household income and more likely to be below the poverty level. So these were the people who were going out, and the essential workers is what we were calling them. I'm going to skip ahead a little bit just to get through a few more slides. What I'm skipping through are, we have a new patient equity measure or metric at Vanderbilt. It's not in our research side, it's in the clinical side. And so we're actually collecting data and setting goals for closing some gaps. Here you're seeing we have gaps in our patient experience. And I won't go into detail here, but again, happy to answer questions. I'll just emphasize that these measures, this patient equity measure, these are now part of our incentive plan for the executives. So these are tied to our executive bonuses around decreasing inequities. So moving on to that third objective I had in thinking about how to make clinical research more scientifically just and inclusive. There's been lots of work done in clinical and translational science awardee programs around the country. I've had the pleasure of working with a number of folks, including on this New England Journal of Medicine perspective that was published a couple of years ago from one of our CTSA meetings, and I encourage you to read that if you're not familiar with it. I'll give an example of how science has not been designed in just and inclusive ways. So this is specific to my background in aging research and Alzheimer's disease research. So we know that there are racial and ethnic disparities in Alzheimer's disease and related dementias among African American and Latinx populations. And we're expecting to see that be even more dramatic as Alzheimer's disease increases in prevalence in general. Of course, a few years ago, after decades with no new treatments for Alzheimer's disease, a new monoclonal antibody was approved for treatment of Alzheimer's disease. If you look at the data that was submitted for that drug to be approved, 3% of that of the participants were Hispanic or Latinx, and less than 1% were Black, even though those two populations, as I just mentioned, are disproportionately impacted by Alzheimer's disease and related dementias. And of course, initially that drug had, many, many thousands of dollars costs per year per person. So the idea is, for that treatment was actually to impact amyloid, which is, one of the two proteins that have been identified as part of Alzheimer's disease. So how do we know, what do we know about amyloid in these populations? So I have been part of a team that's been looking at amyloid imaging and looking at specifically at differences in amyloid imaging across populations. So this initial study that looked at nearly 19,000 older adults with cognitive impairment across the country and looking at amyloid imaging, again, despite knowing that there are disparities in this population, there were very few people who were not white included in that study. So less than 5% Black, less than 5% Hispanic, Latinx, less than 5% Asian. And so when we decided to look back at that original data, we did some matching and looking at those groups and stratifying the data by race and ethnicity. What we found is that people who were Asian, Black, and Latinx were 30 to 50% less likely to have an amyloid positive result. So here we have this new drug that's focused on amyloid, and now we're saying that these populations that are more likely to have dementia may not even benefit from the medication because they are less likely to be amyloid positive, right? So here are these, I haven't updated this in a year, but we had a lot of attention for this paper around the world, and noting that, again, these are people, these drugs, and there have been several other drugs now in that same class focused on amyloid that may not be relevant to or work in these populations. So what should we be doing? So we need to really understand more about these populations. So the next study, so this is an example of how we tried to design the study to be more just and inclusive. So a follow-up study, which is also funded by it was a CMS study. We decided to look at a population that a higher prevalence of a higher number, so not prevalence, a larger number of participants who were Black and Latinx. So in this new study, New Ideas, 7,000 people, 2,000 of them Black, 2,000 of them Hispanic or Latinx. And so these are some of the things that we did to increase the recruitment here. We had materials that we developed that were culturally responsive. They were in Spanish. We noted that there were concerns about exposure to radiation among this population, so we created specific content around that. I'll say that the materials that we created in Spanish were actually we used a transcreation process. So we didn't just directly translate the documents into Spanish. We went, we worked with people who were native Spanish speakers from different countries in Latin America, as well as in Puerto Rico, and said, how would you say this in your language? So we think that process actually is more beneficial in increasing understanding and uptake. I mentioned the Trial Innovation Network, so just want to give a plug here as well that we do have a mass online course called Faster Together that we created. It's free, and so it focuses on how you can increase the recruitment and retention of people from minoritized groups here. This, we actually have an updated version that is going to launch next month that has updated language. So we're no longer saying minorities, but minoritized populations. So what should your just and inclusive research look like? Thinking about, does your study population reflect the people who have the highest burden of the disease? Have you defined race in your research? Are you including social and structural determinants of health? And if you're using white people as a control, why are you doing that? And I think I would emphasize here that we don't want to presume that white control is the gold standard. There's certainly some conditions, and there's certainly some populations, subpopulations of white people, especially those who are in rural communities or from socioeconomically deprived backgrounds, who have worse health outcomes as well. So, making sure you're thinking through what that design looks like. And then the last point, again, I don't have a lot of time to spend here, but hopefully you all are already familiar. I know you have some expertise in this area at your CTSA, but in making sure that we're engaging communities in research. And so this is a graphic that we created some time ago, more than a decade ago, and was published. Here you can see the citation, but thinking about how we engage community in research. And when I initially started to use this graphic, I often got questions from people to say, which one of these is the best levels or ways of engaging community? And I say that you need multiple ways of engaging community. So often, and we have a few projects where we actually have used every level here of engagement. But the dividing line here is really short-term engagement, it's more consultation. And then above that line is a long-term engagement. And of course, there are pros and cons to any of them. We have published quite a bit on community engaged research and projects with community. So every paper here that I'm highlighting has a community co-author. That certainly isn't the ultimate expectation when you're doing community engagement or community engaged research, but just one measure. If I had to tell you the most important, at least in my mind, measure of community engagement in research is that something changed. So you need to be able to point to something different about your research, either the design, the implementation, the dissemination, that changed because you engaged communities. If nothing changed, then that's really not community engagement. And if the sole purpose of your community engagement was to recruit people into your study, that is not community engagement. It's engaged research, engaged recruitment, but it's not community engaged research. I'll also point out a shift in PCORI definitions here. So this is relatively new, and they have moved away from just this meaningful involvement in research to active partnerships. And so the expectation that there is ongoing involvement, so that's above the fold and above the line in my graphic there, that there's ongoing involvement throughout all stages of the research is that expectation. And so again, if you've not seen these new PCORI expectations, I think they're worth taking a look at. As I think about many of the barriers to community engagement in research, I would say, and I've had this conversation with colleagues, that we who have experience in community engagement don't think it's that hard to do. But if you're a rocket scientist, it might feel like rocket science feels to me that, if you've not been trained or have experience in community engagement, it can certainly be very challenging. And so we certainly encourage training, education, awareness, and skill building around how to do community engagement and community engaged research. But for those of us who actually know how to do it, there are many administrative barriers to the work. So we have partners, they're excited to work with us, and then we get to all of the red tape. Like, we expect to treat them as if they are, big corporations. We send them all of these papers and documents to complete. We want them to do the work ahead of time, even though they have limited budgets, and we're going to reimburse them on the back end 90 days later. And so these are really many of the challenges that we've seen in doing our work. And so working with Lori Carter-Edwards, who at the time was at UNC, and people from several other CTSAs, we did some of this work to really identify some of these barriers that we're seeing across different CTSAs. I'll also point out that trust and trustworthiness is something that we encounter a lot, and I like to reframe this is that we talk a lot about community not trusting us, and I say, are we trustworthy? And we created an instrument to measure trust and trustworthiness, and we validated that among Black and Hispanic Latinx folks. You can just see here, the process that we did. We went through. What you see here in red are some conceptions about trust and trustworthiness that we identified among Black and Latinx people that are more nuanced than we see in the general population. So there's a big interest in community benefit, not just benefit at the individual level. This idea of privacy and secrecy is very nuanced in that people from these backgrounds who have been historically abused in research and medicine don't deem us trustworthy. They think we're hiding something from them intentionally, and those are things that we have to acknowledge and not dismiss, because there are very valid reasons that people have these beliefs. In the instrument, there are a number of questions, and I point out here some that you can see. So there are differences by racial and ethnic groups here in the response. And so, this gets to the lumping all, people from minoritized groups into one. We're not all the same. There are differences, people who are indigenous in this country who, have the experience of really being decimated and erased from their own country and marginalized in different ways than people who are Black and, African people who arrived and were enslaved and arrived here, and the descendants of those people versus individuals who are more recent immigrants who have also been marginalized and oppressed in different ways. And so it's important to recognize those things that are similar but also different. I'll also acknowledge here that we are doing some important work with the Compass Initiative, which, when I started my career and started doing community engaged research, I never imagined that there would be community-led research happening at funded by the NIH, but that is now the case. And we have the unique opportunity to work with the Office of the Director at NIH to help build some new resources to support communities and community-led health equity research. Just returned from Montana in the last few days, where we have the opportunity to meet with tribal communities and visit with people on the Crow Nation reservation there to learn about some of the unique challenges they have. But of course, we're talking about populations that have some of the most profound health inequities. And so how do we get them involved and able to receive funds to do research that they actually lead? So I will end here and acknowledge that there are many people who contributed to the work that you've seen, including, help me develop ideas and concepts that are being presented here. And I'm always grateful for the opportunity to share that work, and also acknowledge that there are community members from whom I've learned a lot in this process. So I thank you again for the opportunity, and I'm happy to answer any questions.
All right, well, thank you for a great talk, actually. I'm sure a lot of people have questions or learned a lot from you, so we'll open it up for questions. If you have a question, you can put it in chat or just say it. Chat's fine.
Oh, I see there's things in the chat. I was trying to keep my eye out, but I didn't see.
Yeah, no, the chat was mostly people
asking for information, I see.
Asking for information, and they all want your slides and the recording. So we will disseminate that. As you see, wonderful, very informative. Thanks so much. I agree with Jackie. So any question, I do see some people who are very engaged actually in the type of research that you were highlighting among attendees. So if there are any questions, please feel free.
Afia Cannon has her hand raised.
Oh, great. Afia, go ahead.
I'm not sure if we can hear if they're not a host or elevated.
You gotta unmute her. Afia, you're muted now. If you can unmute.
Okay.
That's right.
Hi, Dr. Wilkins. I truly appreciate your talk. Everything about this was on point, especially as not only being a researcher, but being a Black woman that has participated in research and understand in my community and other minoritized communities how there's a lot of roadblocks, not roadblocks, but a lot of things that stand in the way of us participating in clinical research. I just listened to a talk yesterday that spoke about a huge decline in trust in clinical care in general of minoritized populations. So for me, it's like, okay, if people are not wanting to see their doctor, which is, and I just want to point out that my minoritized population not participating in clinical research is not just because of the Tuskegee and because of other times where Henrietta lacks. It also involves how we have felt being seen in clinical care and other things like that. So just want to put that out there. But so this is already something that has been an issue with us not really trusting clinicians. But with the further decline post-pandemic, to me, oftentimes I feel as though that adds an additional layer to even wanting to present research to someone to participate in. If I don't even want to be seen in the doctor's office, what makes you think that I actually want to participate in a clinical research study also? So how do you work together with clinicians as a researcher to build that trust, or does one have to happen before the other? Do we need to first focus on people building their trust with clinical care before approaching them with research? What are your thoughts on that?
Oh, thank you for the question, Dr. Cannon, and the great insights there. I think the first step is acknowledging that trust and views about trustworthiness don't happen in a vacuum. If you live in this country and you see police violence towards people like you, we know there's spillover effects there on your health. Same thing when you hear about Black men in a Starbucks getting thrown out because for no valid reason, and then you walk into the hospital setting and there's a Starbucks. Those things are not disconnected. So researchers will often want to believe or presume that their work is happening in a vacuum and that people can somehow dissociate. Oh, I walked into this hospital yesterday and I didn't get the same treatment that other people got, but that doesn't have anything to do with us. So it's important to acknowledge again, the connection that these are all fluid and connected, and give people the opportunity to know why you're doing the work, why they should deem you as trustworthy. And I think, the ideas around trustworthiness, I think the most important thing there is transparency. So, are you transparent? What are you doing to indicate that you care about the community, that you care about the work, that this is not just a job, a project, and all of those things are really important. We talk about this in the paper that with the instrument that I mentioned, but also in that course, in the Faster Together course. But you really have to have community buy-in there. So your community needs to tell you what you need to do to be more trustworthy. And so I think that has to be a really important aspect of the work. People who and I'll say as well, people might not trust you or believe that you're trustworthy, but they're still sometimes willing to participate in your research. And so there's a nuance there, and that if they believe that there's a potential benefit for them or their communities, they may cautiously participate in your research. And some people don't understand or get that, but if you are a person from a marginalized background, especially if you are Black or Indigenous in this country, believing that people are not trustworthy is almost a marker of, you know, whether or not you're paying attention, like, because we've been treated poorly, and when we were trusting, we were treated worse. So having some sense of caution is normal for communities. So acknowledging that.
Thank you.
So let me try to get one other good question. How important do you think it is teaching younger people, or even building a workforce that looks like the community in terms of increase in enrollment of these populations?
Yeah, I think this is very important. And again, in the I know Jaleese was putting in lots of links there, so thank you there. If you didn't get the link to the Ending Unequal Treatment report, we talk quite a bit about the need for diversity in the healthcare workforce as well as in the scientific workforce. And so we do need to have a workforce that more reflects the community. And honestly, I think in many ways, community engagement has been used as a bandage for the lack of diversity in our workforce. Not to say that community engagement wouldn't be needed even if we had a diverse workforce, but I think often, you know, we're just grabbing people who have some sense of what the experiences are because we don't have a diverse enough workforce. And so that's really very important. But but there's some nuance there as well. So we don't want a diverse workforce and then have it be segregated. So we don't want to force all of the people from marginalized groups to only take care of people from marginalized groups. We don't want to force all of the people from marginalized groups to do all the health equity research. We want them to do whatever research they want to do. And we need to recognize and value that they're bringing in different viewpoints and are likely to be more innovative in those spaces. And so everybody needs to learn how to take care of all people. And we need to have a diverse enough research workforce that everyone is learning how to embed equity into it. You're muted, Dr. McComsey.
Sorry, I was talking. No, I was just thanking you actually for a great talk and respecting your time and everybody else's time. It's 12, but thank you so much. And the recording will be, as Jaleese said, we'll make it available because I know a lot of people couldn't make it, but they would love to listen to you. So thank you so much, Dr. Wilkins, for making this talk, and very interesting and very informative. So thank you, everyone.
Thank you again. I appreciate it.
Okay.